Welcome to this session. I was just checking the pin boards, and I think there is a lot of consensus that the European health data space gives us a lot of good, promising prospects for the next few years on FHIR. So I'm excited to have this morning a talk about EHDS, and it's great to introduce both José to us, who participates in the extended EHR project on the European level, and René, who also works at FHIR as a trainer, and he's investigating what happens in Europe to prepare some trainings about that. So they'll do this presentation together. Hand it over to you guys.
We're all set. Right. Good morning, and we're doing this as a duo because there's quite a lot of scope, as you know, in EHDS. That's actually, you're thrown into the deep end, and there's 1,000 acronyms, and you have to find out what of all of it is relevant. And that's certainly something we're going to address here. It's not necessarily that José and I agree upon everything, because a lot of details are still open. It's guesswork, but we'll show you something about that. So just as a brief intro, right? Oh, most of you have already know something about the EHDS, but you know the lofty goal is to improve the delivery of care through making data more available, right? So we want to we have the aim to give you a solid overview of EHDS, what are the aims, but also what the impact of the legislation is on the average implementer. That's what we're trying to do in no less than 45 minutes, so it's a bit of a challenge. Now I'm going to start with the takeaway message. It sounds a bit strange, but you will see this slide again. Yes, there are lots of HL7 Europe FHIR implementation guides that try to serve the needs of EHDS, and they relate to the so-called e-health network guidelines, logical models, and cross-border specifications. How? We'll show you that in brief. The second message, a good take-home message, is that EHDS will not pin everything down. We, as standards people, we always hope that governments come up with specifications that are totally nailed down and that every comma and code is fixed. But in this case, that's unlikely to happen, although we don't know. We're going to show you. And EHRs have certain requirements that they have to meet. For example, interoperability stuff, a logging component, and an access control component. And we'll also look at some of the details there. So the aim is to strengthen the rights of the citizens. Think of GDPR. The GDPR privacy legislation actually was already quite powerful when you look at the patient rights. You have the right under GDPR to extract all of your data from any system in a structured, standardized format and upload it in some other EHR. But sadly, no patients have actually done that and taken lots of organizations to court, because you can already do this today. And the EU saw this and thought, well, we need to strengthen the rights of the patients. So effectively, EHDS is also aiming to do that, strengthen the rights of the patients. And also making data better available between the countries, because obviously the EU has the rights to make all sorts of specifications about stuff that happens between countries. So this is uniquely their space, so to speak, to do legislation. And to define common functionality for EHRs. For example, to create a common market for EHRs, so that EHRs would be easier to sell them between various countries. And the bottommost point goes back to my GDPR point again, to support the data portability right. Download all of your data somewhere, upload it somewhere else, if you want to. Now, most of you have seen a variation of this slide in some sorts, but just to repeat, for the first categories up to 2029, we have a certain set of categories that they're focusing upon. So it's not everything, it's going to be staged, but these are the first ones. Now, within the legislation, it actually mentions that there will be some implementation acts. And the implementation acts, they basically take care of some of the details. To us, being in interoperability space, these details are pretty important, right? The structure of the data, harmonized data sets, coding systems and values, and technical interoperability specifications. But what is this going to be at the end of the day? And that's where the speculation starts. We really don't know. Is this going to be FHIR? Is this not going to be FHIR? Is this a logical model? We have no clue. But the legislation itself, at this point in time, doesn't mention FHIR, certainly not anywhere. But a set of FHIR implementation guides already exist, and I'll leave it to José to show you what we already have that we can leverage to support this.
Indeed. Thank you. Good morning, everyone. So we have the regulation is saying that the European Commission shall prepare the European EHR exchange format. So what does that mean? This means that most likely we want to follow from the eHealth network guidelines that define certain data sets, certain data requirements, and we want to have those harmonized. The way that we're currently doing this now, and the XTHR project is advancing on that, is we are preparing logical information models, aka for us, FHIR logical models, where we have the code systems and value sets that we think these are the ones that everyone in Europe should support. There is the master value set catalog. There's a couple of elements that we bring from eHealth network guidelines, but the key point here is that they are not necessarily the same as the eHealth network guidelines. So the project is saying across borders we have some data needs, but in the member states EHRs, we might have other different needs, other different constraints, and that's what we want to capture. So we start capturing the logical information models, which then will be the source or will be the boundaries for preparing FHIR implementation guides, the technical specifications for that. And they will be either R4 or R5 or R6, but that is something that, as René was pointing out, we might not be able to do that within the scope of the regulation. We need communities to consult around this. We need the countries to be more involved. We need also to see how far do we want to go, what is the space that we leave to member states to adopt the content. So that's going to be lots of people participating. HL7 Europe is hosting the discussions for these implementation guides, and some projects are going to support the evolution of those implementation guides. Taking a look at what's the content that we have now, we have the logical data models, so logical information models, that are supposed to be independent from any data exchange standard. So we capture them on FHIR, because FHIR, in that sense, is an excellent way of capturing that metadata, but that doesn't mean that this will be implemented in FHIR. It means that it might be implemented in FHIR R4, FHIR R5, FHIR R6, CDA, whatever is implementation. That's not at our level to decide now. They are machine processable, which actually feed into one of the requirements of the regulation, which is enabling member states to create their data set catalog, to have an inventory of their metadata. We provide the UML for readability, because reading a data model is not the same thing as reading a FHIR profile, so different audiences, so we have to provide as much as possible an easy way to digest this and to validate this. So the validation on this is really important, because if it all comes down to technical people evaluating this, something might be missing. Just an example of the common metadata. This is just some of the models. The goals that we have from the project and from the regulation is that we have findability needs, searchability needs. We need to have access control and logging. We have how do we implement this in a consistent way? So with those kind of high-level requirements, we realized that we needed some things. For example, that we have starting with a document data model. If we want to exchange documents, we have some document metadata that we think should be consistent for everyone. I should be able to look for a patient, search based on the type of document, search based on the date of authoring. This is the common metadata for documents, from which we can have a patient summary as a flavor of that, and we can have the lab report as another flavor of that. So they are both of type document. Unlike prescriptions and dispenses, which might not be exchanged as documents. So they will be more atomic exchanges of data. And unlike the vaccination, for example, or immunizations, which might be part of a patient summary, but might be exchanged, according to the regulation, as an atomic data object that we want to exchange. So in that sense, they are either descendants of the document class, or they are either documents, or they might be some other type of exchange, which is not a document, so we have this as common metadata. The The diagram on the right is kind of the zoom in on that to say we have developed or we have studied what metadata do we want to exchange when we exchange something. If you want to exchange a PDF, at least a patient ID and the date maybe that comes with the PDF, and we know what we are talking about. It's searchable in that sense. If it's a formal structured document, then we have a whole lot of metadata. This would allow us then to create the FHIR implementation guides. Just as an example here, we have the implementation guides that are created by HL7 Europe on the R4 and using R4 and R5. They are going to be used in the different, so we have the commons that are going to be used in the different sub-specifications, and we have a whole lot of implementation guides by HL7 Europe alone. This is not yet when we get to the member states, but this allows us to have a common base, and then we have those that base being applied by all the different implementation guides, which is not just one flavor for everyone. We will have national implementation guides, and this is actually a very important point. The moment that we have an implementation guide for Europe, it doesn't mean that the countries will have to do exactly and only that. Countries will have their own implementation guides, but the cross-border exchange might be and most likely will be different. The value sets, for example, that we use for medication codes will definitely be different within one member state and across borders. So we have to accommodate for different types of specifications, and they both derive from the same parent common European EHR exchange format. So we have the, as I said, the data needs from our project, the extended EHR. We have some challenges in authoring this, and I think those challenges will be seen as countries adopt this. We want to define the data models, but some challenges like what data types do we use? Do we use the FHIR data types, which are kind of physical data types? The solution there was to find out how do we structure the data and the data types in a way that it's not binding to FHIR. So actually this is documented in that deliverable. And we have, by option, one single implementation guide for all work packages in the XDHR project. This is harder to manage because then you have patient summary and discharge report and lab all thinking slightly different things about how to represent the patient and the type of document, and it's harder to manage, but it is much harder to mess up, meaning that if someone breaks something on one side, everyone else will see that, hey, the model has changed. So this is kind of balancing on how do we want everything to be done in their own silo functionally, or do we want one common big pot of specifications? And we have also the value sets for those data models, which again, they are in the same content, in the same implementation guide. And we have preferred the MVC. So MVC is the Master Value Set Catalog from the European Commission. In the logical model, we say whatever happens downstream, these are the value sets that are preferred because they are published by the European Commission, and we should stick to that. Oh, sorry. And just a quick notion on can I do this? We have documented the obligations for actors, and that came a challenge. What actors are we talking about? This is a bit going into the architecture, but what actors do we want to define the obligations for? Is it producer, consumer? Is it exchange hub? Do we consider exchange hub? So what kind of architecture we have? So we have some challenges on how to document these things because we don't know what architectures will be presented. So we have the NCP, so the cross-border specifications. We will have implementation guides that all the member states should adopt. And then we have common things that every member state can adopt and adapt. So cross-border is fixed for everyone. Internal is common, and you can adapt into national implementation guides. So at every member state, what should we do as we work at the member state level? Please, logical data models. So if you document your logical data models, then you can do some semantic consistency checking. You can see how far we are from the commission issued or adopted logical models that we hope to produce. We have the value sets that will be created by countries, and those are expected to diverge a lot. It's I think it's very expectable that countries will have very different value sets for the same thing. and the technical specifications will possibly adapt and adopt, or adopt and adapt part of the common implementation guide, but they will diverge. As long as they are compatible, that will be okay. And I'll hand it over to René for the next part. Thank you.
Thank you. Now, this is mainly a political process, not a technical process. And I already warned you that, especially, I talk to a lot of people. As a trainer, you always talk to a lot of people to find out what should I include in my training courses. But there is the expectation, at least a lot of people tell me they have the expectation that the EU is going to go for the Holy Grail and basically mandate a set of FHIR implementation guides across all European member states. Well, that may or may not actually happen. Okay? To illustrate this, I brought a little diagram. It's maybe stating the obvious, but I think it's worth our while to think about this. So, I have politically achievability on the vertical axis, and on the horizontal axis I have the eHealth network guidelines. Those are really abstract and fuzzy, logical models, and then I go to the FHIR implementation guides. I'm all getting more specific. I'm defining multiple APIs, I'm defining full APIs, I'm determining what architecture the member states should use. Now you can imagine that the further I go to the right, the more opposition there will be to what is created. If I were to state, that's all the way on the left, all patients should have access to their healthcare record, everybody goes, yeah, that's like motherhood and apple pie, as the Americans say. We're all in favor of that. No problems there. Logical models. Well, okay, that still gives us a lot of wiggle room as individual member states. I can kind of live with that. But prescribing a detailed API, we're going to face resistance in some member states. Okay? So I wrote this in red, that it's unlikely that we're going to see specifications in that area, very likely that we'll see specifications related to logical models, and in the middle it's a bit of a swingometer. We basically don't know where we're going to end up. We have to realize, just as a bit of context, that it also impacts the individual implementations in the member states. So here we have our picture with the national contact points. So this is between the various member state countries. And obviously the EU can define whatever they want in this area. And basically, as your average EHR vendor, you couldn't care less. If they use Morse code with smoke signals, I don't care, because it's totally hidden from me. I, as an EHR, I'm communicating with the NCP. So I only care about that particular format. Hopefully it's compatible with what they do between the countries, but right. Now we have some countries, and here I've used Austria and France as an example, that are 100% document-based. Traditional IHE EHDS infrastructure at the national level, for years, lots of investments, billions of euros, in a nationwide exchange of documents. So they have to make this work with the EU specifications. On the other hand, and I used the Netherlands and Estonia as examples here, we have countries that are not document-based. They're based on FHIR, RESTful FHIR, maybe fragments of multiple resources, collections perhaps, but definitely not documents. Those countries have also invested billions of euros in their national infrastructure. So how are you going to create a FHIR specification that's going to be acceptable in both countries? We actually have paid lobbyists that are lobbying for a certain direction of the FHIR specification in the European Commission. Okay, so who knows how this is going to end up? So right now, HL7 and IHE Europe have the enlightened position of creating implementation guides that allow both for RESTful use as well as document use of their specifications. Is that going to remain that way? We don't know. As a trainer, as kind of a neutral observer, I go like, well, you always have use cases that are best served by documents and other use cases that are best served by REST or by some other mechanism. So I think we should not pin ourselves down one way or the other, but anyway. But it just goes to show that it's terribly hard that if you are an EHR vendor, then what should I do? Because I will have to deal with these European specifications and with the national requirements. So in that sense, it's not going to lessen my burden, so to speak. It's going to add to my burden. I will have to create a European API next to whatever is required at the national level. Or maybe not. I see some people nodding their heads. They don't agree with me. That's fine. All of us don't know. Just remember, that's the key point. This is a political process. And yes, we're doing our darn best to create the best possible IHE and HL7 implementation guides to solve this, but there is no idea whether it's going to be used as is, or used at all. But if they're not mandated by EHDS, we still have a collection of very fine implementation guides that most vendors are going to look at as a key example of how to create this sort of EHDS-compatible interface. Right, so patient access, which is one of the other key things here in this legislation. So all patients shall have the right to access their own data and see the logging of who has seen their data. So you could either implement that by an API in all EHRs, or you could have a centralized API on some centralized infrastructure in the country level and access that as a patient. Or you can even create a portal type of thing that is joined up with the national contact point. So that means that all of these systems at the country level, they don't have to support that particular standardized API. They can still use whatever they want, but we can still have at the European level a patient-facing standardized API functionality that allows download and upload. Right? With that, I'm going to hand back to Jose. This is his estimation as to what will be taken up and produced.
Thank you. Thank you, René. So looking at the regulation, what can we realistically expect to be standardized? We will not have one single implementation guide or one single standard that says this is how everyone should do in all the HRs, in every system. By curiosity, the regulation does define what an EHR is. Basically, and this is my interpretation, except for Excel spreadsheets that you actually might use to contain some patient data, should you do it or not, that's another question. Except for existing software, that general purpose software, everything that touches patient data is an EHR system. So every one of those will need to have an interoperability component and a logging component, so that we are set for that. Now, can we say every one of those will support CDA and FHIR in one single flavor? That's not going to happen, in my opinion. Standard processes. We all know that processes cannot be standardized. Healthcare processes will vary, they will depend on legislation, and since the solution is let's just have one way of thinking for the whole of Europe, that's also not going to happen, in my opinion, as well. So we have different workflows, we have different architectures, and that's okay. But we can have standard components and services. So the regulation, I'll show a few, the regulation does say there are a couple of key points or components in the architecture that we expect systems to have. So we can say, for example, looking at the analogy with actors, we can say there will be a patient summary producer. That's fine. However that happens with a machine or with a man or hybrid, we know that someone will create a patient summary. I think that is very likely to be standardized. This component shall behave like this. It shall be able to produce this kind of data, shall be able to display this kind of data. I think that's okay. On the standard interfaces, sure, but not the technical specifications. As discussed before, we will not have all the nitty-gritty details, everything carved out for every single implementation. One of the issues that we have now is the expectation, as René was saying, that the Commission will give us everything and we don't have to think, we just have to execute. That's not going to happen. We, as professionals, we have our job to say, to advise and to say, how will this work for us? How can we stay within these boundaries that are quite broad, but making it work for our countries, for our systems. Whether it's a national contact point, national infrastructure, or each individual vendor that has to support this. We will have most likely the semantic specifications as standard, data models, glossaries, and value sets and code systems. So definition of what is a patient summary producer, what is patient gender, what is patient given name. Those are things that we can agree upon, and those will most likely be consolidated for now on. Every single model will derive from this, or every specification will realize this model. And we can expect those to be standardized. And very important, conformance criteria. We will have, most likely, some standard criteria for how to test and how to validate that these components, they are doing what they should be doing. So those are the kind of areas that I can expect some standardization to exist. So how does this mean in terms of IGs? What implementation guides will exist after the EHDS starts? The member state-based implementation guides, my opinion, from my experience, is that they will remain. So we cannot say, let's forget about national base, national core, because they will be replaced. They won't. They represent the national specifications, what we have in Belgium about the slices for patient identifier, what we have in Portugal about the needs for some other data elements, those will remain. Those represent the legal models, legal terminologies, and legal specifications that are in the country. We will also have national purpose-specific implementation guides. Those will remain, so the national specification for a country will remain, will not be the same as the European. What we want is that it is compatible with the European specification. For example, can a patient summary issued in Finland be read by a patient, by a hospital in Portugal? That is the expectation, that to a minimal data set, to a minimal set of data elements, yes, that will happen. Lot of information might be lost, but we have to ensure some common compatibility. But the national ones will still exist. So what's the impact of all that? If we have I think that's the poster outside. René will share his conclusions.
Well, you can interpret
Yeah.
this as well, since we didn't prepare this. Okay, so I did a little poll in this session. Okay, only 17 people responded, so it's not statistically valid, but anyway. It gives you an idea. I was asking for, what are you expecting the EHDS to standardize? Logical models, FHIR IGs, exchange models, national exchange architectures, or exchange architecture in general, security architecture, access control rules, and you can see that the highest score is actually 65%. So people in this audience also don't know what to expect. That's more or less my conclusion of this particular poll. Okay, so we have EHRs. And those EHRs have requirements, functional requirements, and other requirements. And José will speak to some of the details again, but EHR, it has already been mentioned. EHR is defined as a very widely defined in EHDS. So be warned, it's, as you said, any system that touches healthcare data, more or less, from your device, clinical device, up to what we internationally mostly understand an EHR to be, and all of that is an EHR. So on purpose, actually, they used a pretty wide definition here, I think, as a starting point. So all of these EHRs, according to the EHDS, will have an interoperability component. Well, we already heard something about that. A logging component, probably based on IHE Aetna, if you're already aware of that. That's a well-established way of doing auditing. An access control component, think of patient access rights and all that sort of stuff. And conformance documentation. You will have to self-certify against a test suite of stuff, and then basically as a vendor you can produce a conformance statement. But you will speak to some of the details of that as well. So for the details, over to you again.
Thank you. So one point here is that all of those should be conformant or should be relating to the common data set. So if I have a logging component, it actually should be saying a person with this role has used the data for this patient for that purpose. So all what I said, these should be standard data elements, because what we don't want is somehow through the cracks we lose patient rights. Speaking of patient rights, I was going to make a poll, but I'm kind of curious now with how many of you actually think that security architecture is going to be standardized. Well, like too high of a percentage from the poll that René showed. But here's an example of access control. So the diagram on the right is my interpretation of what literally is said in the regulation. Basically, it says patients have the right to access data, they have the right to trigger the portability of data, and they have the right to mandate someone to access their data. By the way, before any further discussions on this, data access rights are not absolute. And finally, the EHDS says it very clearly that if there is some diagnosis that the patient really, really should not look at this without the presence of a professional. This is called out explicitly. Patient right to access data is not absolute, and also patient right to opt out, it is not absolute as well. So this is written down in the regulation, so we have to follow that. But the patient can mandate either a proxy, or there might be a legal representative who also have the right to access some of the data, again, for some of the purposes. And this means that we'll have all those components, the interoperability component and the logging component. And we will also have, or we might also have, a notification service. In some countries, when anyone accesses my data, I get an SMS saying this person has used the data. This is just a component. The regulation doesn't say it shall be implemented for that one. It does say the interoperability and the logging components shall be implemented, but it doesn't say the details of that. So what we have is, how can we make this business requirement set, this set of higher level components, work in technical specifications? How do we do proper patient and user identification? How can I, here's an example, how can I make sure that because of the difference in granularities of the roles, the professional roles, like nurse categories, that I can expect to come to the Netherlands or stay in Belgium, and the data access rights will be preserved? Or in other words, can I make sure that, well, I cannot get my data in, as a nurse, I cannot get this data in Belgium. Let me go across the country or across the border and use the same thing, but I have a different category of nurse, or this maps to a different category of nurse, and then in that country I will have access to the same data that I shouldn't have. So role-based access control actually requires standard roles for this. Standardizing those things is going to be difficult, or having some mapping, some consistency. That is going to be important, but very big challenge to prevent exactly, for example, abuse. So just on the right, we have some things that we might expect to be allowed. Patient can access their own data, can authorize a proxy, as I mentioned. Obligations, access must be audited. And prohibitions or interdictions, some things you cannot say. Charging for access or making technical barriers for access. This is also important because we cannot, the regulation does not allow systems to say, we would like to have that, but we need to charge the patients for access to the data. That is explicitly excluded in the regulation. So we have, just on the access control, the regulation, the EHDS, is really rich. It bases itself on GDPR and other regulations, but it's really rich and it's really detailed, and it's worth the analysis just to see what is it actually talking about. One of the things that it does propose is, or it does present, is there shall be documentation of conformance. For every HR system shall declare their conformance to the specifications. What those specifications are, again, workflow specifications, actor conformance, data set, code system, terminology compliance, all those things will be discussed, but the moment that a vendor wants to be in the market, they will have to have their declaration of conformity, like the CE stamp. And this should be affixed by manufacturers in the documents accompanying. Of course, I'm thinking QR codes in the systems, but whatever. So how do we declare that? For us, it's kind of easy. We have FHIR capability statements that can help a lot in this, but what to declare? Conformance to what? Am I conformant to the extended EHR, to the European EHR exchange format, or am I compliant with the prescription producer in that, using that format? So we have to see how granular do we want to declare that conformance, and that will be necessary, what's necessary to test. I cannot say my system is conformant with the whole of EHDS. I don't think we'll see many systems that are going to be trying for that, but I can perfectly say my system is conformant with the prescription placer or prescription producer as described in the specifications that come from the EHDS. So how do we assess this? We will have some discussions, some tooling, some initiatives, but wanted to present first the regulation and the platforms that we have. So the regulation, the EHDS, says explicitly the Commission shall prepare a European digital testing environment for assessment. So this is stated there, the Commission shall prepare this. And this can be hosted maybe like by the Commission or by member states. This means that every member state should be able to run their tests themselves, because again, if a member state has specific requirements, I don't want to test in Belgium the requirements for a French system, unless we really want to study how that's going to work because the vendors require it. But member states should be autonomous in producing those test results. So what is a testing environment? In my view, is a testing platform, for example, the one from the Commission, the interoperability test bed, but this also means testing procedures. It's not that we have a system and that's it. How to test these things? What are the levels of testing? What are the degrees of testing? What are the details? What is the shoulds and the shalls and the musts? And we also need to bring up the test data. So with which data are we going to do? That's part of the testing details. So for us also as an impact, and there's some progress, good progress happening there, we might have, in addition to implementation guides, we might produce testing guides, testing packages of content that are telling us what criteria and what test data to use when testing the systems. So they will most likely have, the member states will most likely have those tools. And just one, I think from this slide, the key thing to retain is there will be stages in adoption. I don't want to be compatible with everything all at once. Maybe I start with at least my documents, my PDF documents that I have as legacy. They will have a patient ID and an author name or ID and a date. If that happens, okay, at least we can do something with it, we can test for that. But then in the second stage, I want my documents to be properly structured. And in the third stage, just thinking of possibilities here, they will be structured and with the proper value sets. So we have different criteria for maturity. We want to have those criteria very, very clearly stated, and that would allow member states to say, I'm on level 3 on the patient summary producer, I'm on level 1. And that is something that we can expect to be running synchronously, rather, in the countries. So just some upcoming developments in terms of tooling and ecosystem that we're having on FHIR. You've heard this week about the multilingual implementation guides. I do not know how strongly this is going to be used in the context of the specifications, but at least to allow people in the different countries to relate to those models that they have to produce and to the specifications, I think this is going to be a very big impact. Testing package enhancements is more technical, so we have been working on the test plan and test cases resources and how do we use them. So there's going to be some evolutions on FHIR on how to do this. There is a rather good feature in the FHIR tooling to generate test data, which is going to be really important for this. We also have some integration roadmap with the interoperability test bed. So there is FHIR on one side for FHIR authors and the interoperability test bed from the Commission. How do those two integrate? And at least for me, very interesting is the integration of metadata. So how do we use FHIR to generate everything that the EHDS says that we should? The terminologies, the data models, how do we use FHIR for this? And how do we create catalogs of those things? So there are some things happening in FHIR in terms of creating implementation guides, creating test data that it should be important for us to have a successful adoption of the EHDS on FHIR.
Thank you, which brings us back to the summary, actually, the thing that we talk about and the takeaway messages. And the thing is, if we look at the pin board, okay, that's your opinion, effectively, so this is much more representative poll of this particular audience. There's actually two things where we have a clear opinion. So will EHDS lead to a unified EHR market in 2030? Well, maybe, but there's not a lot of enthusiasm about it. But on the other hand, everybody expects there to be a strong increase in FHIR. On the other ones, the jury is out. You can draw your own conclusions when it comes to that. Go back. Yes, we have this whole set of FHIR EU implementation guides, and Jose gave you some of the details, and we saw the relationship with logical models. EHDS will not pin everything down. And why am I repeating that? Well, this is the misconception that I see most often in people's minds. Before we close, okay, there is kind of a mini EHDS track today. So we have a session that follows on, actually I don't have it on the slide. There is a session on the EU lab implementation guide. We have a presentation on the pharmacy stuff. So the only thing we don't have is the imaging guide, because that was already on Wednesday, I think. So that's it from me. So on behalf of us, you're welcome to discuss. We don't have a lot of time anymore, but you know where to find us. And I think all of us will be in discussion around this topic for a while yet, before we actually see the implementation law of 2027. Only then will we actually know what we have to do.
Can I have some sound? Yes, thank you. We have a few minutes, 3 to be specific, before the coffee break. Is there anyone who dares to ask a question? I'm going to go all the way over here.
Hey guys, I really appreciated like the kind of nuance and like intelligent and thoughtful approach to like what's actually going to happen, right? I think that this is refreshing and also, you know, a little scary at like just how broad and how diffuse and the requirements and specifications are actually going to end up being. And I also appreciated like your clarification of what the definition of an EHR is. Like it's not really like what we think of as an EHR. It's really just, you know, medical technology or, you know, med tech software, period, right? I think that's right. But I did want to just kind of maybe ask you, I think that referring to like just the disparate nature of the FHIR specifications that are going to be mandated across the EU, as I don't think it's really an EHR burden. I think it's going to be a health system and national burden and increase the cost of healthcare. And it's going to be an EU burden because it's going to like fail to create a common market, I think, as we really saw there. And then I think it's also going to be a patient burden because we're going to not see widespread patient access ability here. We're not, you know, a Canadian IPS won't be interoperable in Portugal, for example. Any maybe reaction to that?
I can have that. Sorry, quick reaction. So we expect that, at least it's a proposal, that every patient summary, so actually every one of those categories, they shall be compatible with the international norm. So we have, for example, I expect that all the prescription systems in Europe will be compatible with the IHE international prescription specification. And a better example is every single summary, patient summary instance that produced in Europe in the EHDS, hopefully will be, it's a requirement actually that we have, is to be compatible with the IPS. That means that if you use Canadian values there, then they are not going to be ready in Europe, but that's life. But I expect them to be compatible to the course. That has to be a requirement that we have, and for the patient summary is a concrete requirement. We cannot avoid the difference in member states, but I do expect that, and this is a requirement for the patient summary at least, that every single instance of every member state will be compatible with that member state and with the international core. So for the patient summary, we already have the specification of the IPS, and that's what we are following. So yes, it will lead to more interoperability, many more challenges that come with it, but I think that should be our expectation.
With that, we are through our time. Thank you all for being here. Thank you for presenting. I think there's fresh stroopwafels during the break, so I would recommend.
Enjoy the stroopwafels.